So good afternoon, everyone, and welcome to Joint BRI Educational Curriculum Knowledge Connections. It's my pleasure this afternoon to introduce Dr. Emily Seto. Emily is the Academic Director of the Masters of Health Informatics program and the lead for Health Informatics within the Health Services Research Program at the Institute of Health Policy Management and Evaluation at the University of Toronto. She's also an affiliated researcher in the Center for Global eHealth Innovation and the Techna Institute, both at the University Health Network. Emily's research interests revolve around the development, evaluation, and sustained implementation of mobile healthcare technology to facilitate patient self-care and clinical decision support for chronic disease management. She has 15 years of experience researching in the field of health informatics and has particular expertise in the area of human factors and medical imaging. We look forward to your talk, Emily. Thank you so much for joining us this afternoon.
Thank you, Tom. So today I'm going to be talking about some of the work I've been doing in the field of mobile technologies in health. And I titled my talk, The Promise and Reality of mHealth. So I'll try to touch upon what the potential of these technologies are in healthcare, as well as really what is happening. So before we get started, though, on that, I wanted to take you back on a journey of how we started with mobile technologies in general. So this is Martin Cooper. In 1973, he helped develop the first commercial mobile phone for Motorola. And I don't think people should complain about their size or the cost, because this phone weighed about 4.4 pounds, and it was about $4,000 back then, which is about $10,000 now. So that's where we kind of started off, and it took 24 years for us to get to the Palm Pilot. And I'm looking at the faces, and they're all very young, but I remember the Palm Pilot, yes. Yes, it was so cool. It was so cool, and it was like, you know, you could graffiti, and you could write in a different language, but you could put your contacts in there and everything. But it took another 5 years for RIM to come out in 2002 with the BlackBerry. And this was really revolutionary in that now you could get email, right? So this was really a big step. And it wasn't just a pager anymore. In 2005, the term mHealth was coined by Robert Stepanian. And there's all kinds of different definitions around mHealth, but I kind of look at it as the use of any type of mobile devices for any kind of health-related activities. So 5 years or 10 years after the introduction of the Palm Pilot, 5 years after the introduction of the BlackBerry, we have the iPhone. And this, again, was revolutionary in that it was a touch screen, had color. And what's very interesting is that if you look at the iPhone from 2007, it looks almost the same as it does now, right? But what really has changed in the past 10 years or so is the applications, right? So especially around healthcare, in 2015, what we had was the health app, right? And so this was a way that Apple was trying to get all the health information onto one dashboard. They had, HealthKit, where developers can try to develop their own apps to feed into the HealthKit. And we also have the Apple Watch, right? So now we have devices that have things that are integrated already in there so that you can do things like fitness tracking, et cetera. So this is a graph from PEW Research Center, and it shows the ownership of cell phones over the years. And I like this graph because not only does it show the US rate, which is similar to the Canadian rate, about 90%, but it also shows the penetration in some low to middle income countries, such as South Africa, right? And you can see it's the same penetration. And they are using cell phones in a very interesting and novel ways as well around HIV and maternity health. But what is different is around the smartphone use. So here you can see around the US, it's about 64% of smartphone penetration, less in those kind of middle to low income countries. So here's some stats. There's about 7 billion people on the planet. There's 6 billion people who own a cell phone. And this really eclipses the number of people who own a toothbrush or even have access to a toilet, right? So it kind of says something about the state of what people find value and the ubiquity of the use of cell phones these days. So I came across this term a while back. And has anybody heard of the term Nomophobia? Yeah? No? So this has actually been scientifically researched, and there's papers out in the scientific journals about this, and they even want to put it in the Manual of Mental Disorders, so this is the official Manual of Mental Disorders, and it stands for no mobile phone phobia. Right? You might have been able to guess that. So again, it's changing the way that people behave with mobile technologies, and this is a quote: "Cell phones are possibly the biggest non-drug addiction of the 21st century." And certainly, the other day, I was this was a few months ago, I was on the subway, and I was trying not to be too creepy, but I was working on my cell phone, and so I looked up, and everybody else was on their mobile devices on the subway, right? So I took a picture, and again, I hope I didn't creep anybody out. But it was just kind of amazing, like myself included, is that now it's so integrated into my life that I don't even notice that the way that I work and the way that I interact has changed. So whether it's an addiction, source of phobia, or is it really just the new norm, right? So things have definitely changed over the past decade or so. Okay, let me switch gears a little bit and talk about healthcare. So you might have heard, and I'm sure you know, that about 75% of all healthcare dollars go towards spending on people with chronic diseases of the 7 above here. And the 5% of the people who are the really sick people, those people, they spend about 60% or so of all healthcare dollars. So those are the very complex patients that I'm going to be talking about first. And then beyond that, there's a lot of people who right now are either in the well population, and then also those who are really kind of managing okay their conditions. And again, there's applications for mobile technologies, which I'll touch upon later. But let's talk about the sickest of sick patients. This is a real huge problem, right? Because chronic disease rates are increasing about 14% a year. Right? And it's maybe not that surprising, because if you think about it, people are living longer, right? Medical advances are leading to longer life. And unfortunately, people are getting sicker earlier, right? So this is some stats about the increasing obesity rates among children, right? So they're getting sicker, they're getting diseases like diabetes way earlier than their parents. So the question really is, can mobile technology help with our sustainability of our healthcare system? And what I get asked a lot is, well, okay, so people use mobile phones, but how about those old people, right? Those are the people who get sick and have chronic diseases and are those sickest of sick patients. So what we know now is, according to a Deloitte study, is that the segment of people who are over 55 years old are the fastest growing market in smartphones. So, and my mother is actually using a smartphone and texting me, which is crazy, right? So I believe this. In terms of smartphone owners, about a fifth of them already have a health app. Okay, so maybe not surprising is that it's all clustered around exercise, well-being, diet, food, and that sort of thing. But for the people who are the sickest of sick, right, they are not using it that much yet for things like blood pressure measurements, for blood sugar monitoring, that sort of thing, or medication management. Any guesses to how many healthcare apps are out there in the different app stores? Any guesses? A little less than 1 million. Less than 1 million. Any other guesses?
10,000.
More than 10,000. I ask this sometimes, and it's funny. Somebody always gets me really high, somebody really low. It's somewhere between, more than that. So you're getting closer. It's over 165,000 apps right now. And you can see that they're really clustered, again, around wellness management, right? And again, perhaps not that surprising. But what is kind of interesting is that 36 apps account for 50% of all downloads, right? And 40% of apps are really not being used. Okay, so what does this mean? There's a ton of apps out there, but some of them are kind of crappy and nobody uses them, right? And so when we want to choose apps, how do we do that? So I think that really what helps is if it comes from a trusted source, right? So if it comes out, and this is an example that we did, was partnering with, for example, Heart and Stroke Foundation, right? People recognize that. So if they put an app out, people have some sort of familiarity with it and trust in that app. Also, there's a very interesting notion around prescription of apps now. And so it's almost like prescribing medications, but instead of prescribing medications, a doctor can prescribe an app, right? And again, it's been shown that retention rates, so people keep using it, if the app has been kind of prescribed or suggested by their physician. And for the sickest of those sick patients, what I think is really important is that it has two purposes. One is to improve self-care, and the other is it has to link to clinical management, right? So those sickest of sick patients cannot do only self-care, but they do need tools to help them. And again, we've kind of found out that patients, and I've included their family caregivers, they want to do self-care, right? They want to be able to participate in their health, but they need tools and they need help. So let me give you some concrete examples. So this is Fred, and he actually participated in one of my studies. So he's a typical heart failure patient. And he's one of the luckier ones in that he belongs to a fantastic heart function clinic at the University Health Network. And I say he's lucky because about 50% of people with heart failure apparently don't even have a cardiologist, like don't have a clinic they go to, and they just have their family doctors who take care of them. So Fred, being one of the lucky ones, he'll come to the clinic on average maybe every 6 months, right? And all the time between, there really is not a lot of information of what's happening with Fred. And he's not alone. There's about 500,000 people in Canada. It's really expensive, right, to treat cardiovascular disease. And it's one of the most common reasons for hospitalization, which is why it's so expensive. But what's encouraging is that up to about 50% of these hospitalizations can be avoided, right? So how do we do that? So this is actually, I won't even show this video, but he's showing you the app that we've created, and I think I'll just talk through this. But so to help Fred, what we did was at the Center for Global Health Innovation, which is where I do my research, we have a group there, and it's made up of a variety of people, including designers, engineers, project managers, a lot of students, human factor specialists, and graphic designers. And we work together to develop applications. And the center does a lot more, but that's a whole different other talk. Because I'll talk about the part that's relevant to our mHealth discussion today. The other part that's kind of interesting and relevant is that we just got ISO 13485 certified. And there's probably some engineers out there who might know what that is. I don't know, maybe not. So this is important because it's a quality management system. And it's international ISO, it's an international quality management system. And to get certified means that we have a quality management system that is equivalent or useful when developing medical devices, right? So the concept of whether or not our devices right now, apps or hardware, is a medical device is a slippery kind of scale, right? So we've been talking to Health Canada over the past few years, and honestly, sometimes they say they're a medical device, sometimes they say we're not. The latest one, we're not, but it has like these very complicated and detailed discussions around what is a medical device and what isn't, because those kind of policies are always kind of lagging the technology. So at this point, we're certified so that we can develop medical devices, and we're certified to do that. So at the center, we use what we call a research-informed user-centered design. I'm not going to belabor this, but we do have an iterative way of developing, starting from concept to design, and it's often quite honestly just on paper. Then what we do is evaluate through usability testing, so we bring in the end users. So we always bring in patients, clinicians, whoever's going to be the end users of our products. We feed that usability testing back into design and concept phase, and then once we have something we can use, that's when we start the pilots up to the randomized controlled trials, depending on what makes sense. But really what we're trying to get at is that implementation stage, right? And I'll talk a little bit about that in a bit. So let me show you one of our apps. This is Medley, and it's actually a platform for chronic disease management, and it has modules. And what's unique about this is that it tries to target people, again, those sickest of the sick patients. So, and you probably already know that those sickest of sick patients don't have just one disease, right? They have multiple chronic conditions. So we have modules that we can mix and match depending on the individual patient, and the app will respond depending on their mix of chronic illnesses. So as I mentioned already too, is that it tries to target two areas. One is in self-care, so it empowers the patient by giving immediate self-care messages based on their readings for that day. And then it also provides information for their healthcare providers through alerts and also additional information about their patient. So let me explain. This is how Medley works. So we have the kit that we give to the patient. They take it home. They answer questions about their symptoms. They take their parameters depending on the disease, like their weight and blood pressure, And then this information gets automatically sent from the cell phone, which is kind of like the data hub, and it sends it to our Medley server. There it has these algorithms that we've worked really hard with the clinicians to make sure they're safe. And it automatically sends a self-care message back to the patient, and it also sends an alert only when necessary to the clinician. So this is important because we never expect clinicians to look at reams of data, right? Because that'll kill your project right away. So only alerts at the times of need, and then they can loop back to the patient as necessary. So here's a picture of the kit. As an example, we have Bluetooth-enabled devices, the blood pressure monitor, weight scale, and the app. Here's some screenshots. The homepage is meant to, and again, we did lots of iterations of this. The homepage shows you what you need to do that day in terms of taking measurements, and it also gives you a snapshot of how you're doing. And then the middle one is simple yes or no symptom questions, and then we have ability to show trends as well. This is an example of the feedback, and it's one of those more contentious alerts. Because I think a lot of people get kind of nervous. So it basically says, follow your doctor's order, take another dose of Lasix and restrict your salt and fluids. And I get this asked all the time, isn't that really dangerous? You're telling them to take meds and it's automatic, right? So this is kind of like one of those things that, and normally that would, prescribing medications would totally shift you into the medical device realm. But because certain patients in heart failure are already told to take Lasix, when, for example, their weight goes up by 3 pounds or over this threshold, they're told to do this already as part of self-care. But they don't often do it because they get nervous, right? So they don't want to change their meds on their own. But the doctor tells them to do this, to take another dose of Lasix, which is a diuretic. So this is kind of reinforcing or kind of reminding them what to do. On the clinician side, there's 2 ways they get information. One is through the dashboard, which is just a website they go to, and they get all the historical data and all the information about their patient. But what we found very effective is that we send an alert via an email to the doctor's or the nurse practitioner's own mobile phone. So they don't actually have to log in at all to the EMR, which I'm not sure what your EMR looks like here, but UHN, there's some challenges, right? So we provide in that email all the information they need about the patient, why there's alert to their medications, their latest lab results, et cetera. And very importantly, we have the patient's phone number on there. So all they have to do is actually tap on that phone number, and they're connected instantaneously to their patient. And we found this has worked extremely well. So in an old version of the Medley platform, which I showed you, we did do a randomized control trial. I'm not going to belabor this, but we had 100 patients randomized, followed for 6 months, mixed methods. And what we did was we found that there was some encouraging results. So quality of life improved, self-care improved, and when we did a subgroup analysis, taking out new patients, because again, our heart function clinic is superb. So these new patients coming in as a control group were actually improving. So we took out the new patients, so they were all at kind of like a really stable line. We found that the brain natriuretic peptide, which is a biomarker, a prognostic biomarker for heart failure patients. So basically, if your heart's working too hard, BNP gets released. So you want to reduce that. And the left ventricular ejection fraction, they both improved by clinically insignificant amounts. And again, this was a very small sample size, so we were very encouraged. What other things that we found out was adherence. So I'm sure all of you have downloaded apps, and in the first couple of weeks or a month, you stop using it, right? The honeymoon phase is over. And so what we found is that even after 6 months, right, which is quite a long time, people were still taking their measurements on this app 5 days out of 7 days on average, which was really great. And we had lots of, heart failure is kind of like an elderly chronic disease. So we had like elderly patients using this without problem. And again, the older version we had was nothing like our current one, because this was done about 5 years ago. So it was done on the Pearl. I don't know if anybody remembers the Pearl. It was like the old phones. Anyways, so we had, they were able to do that. And we even had like 80, I think our eldest was 88 years old. And part of the good thing about using mobile technology is that he was going to go fly to Florida. And apparently Canadians do fly to Florida, elderly people who'd retired, they fly to Florida in the winter. Several of them did. It was kind of an eye-opener for me. But so the one said, okay, I'm going to Florida for, 3 or 4 months. Can I bring my kit? And I said, well, if you have cell phone coverage, bring it. And so he actually brought it to Florida. Our clinician here monitored him while he was in Florida for 4 months, and he did his measurements every day. So, again, the strength of mobile technology. And on the other side, and I don't recommend this, but at that time we had Dr. Heather Ross, who was managing some of these alerts. And so she was kind of a bit of a control freak. Don't tell her I told you that. But so she wanted to monitor all these, even though I think a nurse could have done it. So she took her phone with her everywhere she went. And so she even was on the beach in Bermuda, and she called one of the patients because it was an alert, right? So again, not that we recommend that clinicians do that, and no other clinician probably would, but again, the power of the mobile phone, where you could do healthcare pretty much anywhere you are. In terms of the patient perspective, they thought they were being more responsible, accountable, and they also thought they were changing things about their life to make things better, which was, again, very, very encouraging. They felt like they were participating in trying to keep their health. So this is Dr. Heather Ross, our clinical champion in this project. And from the clinician's perspective, they were able to detect very early on, before they needed to go to hospital, if there was like the early sign of them getting worse. Right? So way before that they need to go to the emergency department, a jump in the weight, they're feeling fatigued, they would catch that so they could change their medications, they could call them into clinic, they could educate them about food, that sort of thing, way before the need to progress to hospitalization. There was also improved communication with the patient. So as you imagine, patients thought it was gold, right? So they would get a call from like their cardiologist. I mean, it was crazy, right? So that communication at the time of need, and again, that concept around teachable moments, right? So when you're diagnosed with something, you get education, and they remember probably nothing about that, right? They hear they have a chronic disease, and that's about it, and then in the car. So at the time when they actually need that information, it's not there for them, right? So what this tries to do is that when they are getting sick, there's that reinforcement through the self-care messages, there's that reinforcement through the clinician, right? So that teachable moment. So we thought, okay, this is great, right? We're doing such a great job. We're going to replicate this into the home care nursing setting. Right? And we thought this was going to be so easy. I had a master's student helping me on this. We partnered with PEng, which is a home care nursing agency, they were really great to work with. We also partnered with CellTrack, which is a company which, amongst other things, they create software that the nurses have on their cell phones. So in the field visiting the patient, they could document and also get patient information. So we thought, okay, this is going to be great, We had so many problems here, so we learned a lot. And here, I'm just trying to summarize some of the challenges that we had. And to put in context, we just wanted to do a feasibility study. We wanted 10 to 15 patients. I had this master's student. I thought, okay, this is a great project, right? You're going to be doing great on this. So after 5 months, we got 6 patients, right? And it wasn't for lack of trying. We had half of them drop out. The poor master student, he did 11 workflows because the workflows of these nurses was so complicated, and he kept on updating it. He had to teach 60 nurses about our system because they could not identify which nurse would get called to which patient. There was reimbursement issues around paying for what we call phone visits, which is really just a phone call. Like, there's no way to bill for that in our healthcare system. So we had to pay for it in our study. And one of the major problems was contacting the most responsible physician. So you can imagine here the nurses in ParaMed who really aren't mandated to kind of make these decisions around medication changes, right? So they didn't feel comfortable doing a lot of this, so they would have to contact the physician. And these physicians are in the community, right? So you can imagine the phone tag that ensued, right? Them trying to contact them. The physician has only certain working hours, and they're seeing patients. So then there was a delay in getting back to the patients. And again, this was leading to a lot of frustration for the patients and for the nurses. And I think that's partly why the dropouts happened, but there was a lot of other factors. So we learned a lot from this, but we didn't learn that we should just stop. So we did another model where we looked at implementing this in primary care, and we actually are in the middle of doing it right now. It's again very interesting looking at different service delivery models and how this type of technology can fit into our very complicated healthcare system, where there's different ways of getting services as a patient. So right now, I really can't tell the results, but we've been in about a year, and we still have less than 50 patients enrolled. So there's been we're having a lot of difficulty identifying patients, which is very interesting in itself because we have about 80,000 patients in the FIT, right? So we're working with David Kaplan, and he heads the North York Family Health team there. So we have access to 80,000 patients. And so we thought 100 patients, no problem, right? And we've been trying everything to identify the right patients, and it's been a real slog. But learning a lot from here. So we are no strangers to trials. I've listed just a few around some of the technology that we've done in mHealth around different chronic diseases, looking at different service delivery models, and you'll notice a ... because there's many more that I didn't list. And so one of the conditions that I think that we as my team have been kind of afflicted by is a chronic disease called pilotitis. And I don't know if a lot of you our researchers probably have come across this or are afflicted yourself, and I sympathize. And so we've been doing this for about 10 years plus, and the number of pilots we've done is pretty astounding. Some of the results we got are fantastic, showing changes in blood pressure drops, like significant ones that rival medications, right? But how do you implement this, right? And kind of referring back to thinking back on why this is. I kind of outlined some of the things that we've run across. And certainly the lack of funding is a big one, right? So what is the business model in terms of implementing some of this new novel innovations? There's also misaligned incentives. So for instance, as a hospital, do you really get a financial incentive to reduce hospitalization? Because you really don't. You don't get money for it, right? And in fact, you just get filled up with another patient, right? So spending that money to implement these novel innovations, not so much there. Lack of reimbursement methods. So perhaps a call, maybe an email is the best way to contact your patient, most efficient for everybody, including the patient, right? But yet you can't bill for it, so you never do it. So you drag the patient in, your wait time gets longer, et cetera. Contradictory evidence is one of my pet peeves around this area. So there's been a couple, now 3 actually, very large studies around mHealth, especially around heart failure. Hundreds of patients enrolled, and they found no change, right, using intervention. But if you look at what they're rolling out, there's no question of why this is happening. I mean, their intervention is missing very fundamental key things, such as getting self-care feedback to the patient in a timely way, right? And some of these have extremely high dropout rates. So they're not using the intervention, so why would you think there would be a health outcome out of it, right? So it's very fundamental things, and it kind of hits at the whole area of why people don't want to invest in this area, because they say, oh, they'll quote this study, and it's, as I said, a bit of a pet peeve of mine. And the last one is around our healthcare system. And I think I tried to explain through that example, some of the very complicated workflows we have, all the different ways of insertion of this type of innovations. So how do you do it, right? So I am happy to announce we are in a state of remission in our pilotitis. Couldn't be more thrilled. We're launching a real live program at UHN, actually 2 programs around telemonitoring, around the technology I just explained to you. So one of them is going to be in the heart function clinic. And it really was, those stars aligning, or that Swiss cheese model where all the holes align for this to happen. So you probably have heard there's that huge donation by the Rogers family for cardiac research, right? $130 million spread to UHN, SickKids, and U of T. So our clinical champion, Heather Ross, is kind of heading the UHN component, and she has promised a reduction of hospitalization by 50% in the next decade. And she made apparently an equally hard goal around reducing mortality around heart failure patients too, that I think maybe she's regretting at this point. So she's doing this multi-pronged approach. I mean, this is huge, right? 50% reduction in hospitalization. So she's doing this multi-pronged approach, trying to put in some novel interventions. There needs to be a step, right? Something drastic needs to happen for her to meet this goal. So Medley is one of those kind of pillars. And in terms of reimbursement models, we're very lucky because we have these great nurse practitioners in our clinic, and they're salaried. So they're already doing this work. And in fact, we're trying to help them do their work. Right now, those sick patients, what they're doing is getting emails sometimes or phone calls daily about their weight. And I don't know how they manage this, because they need to go get this number, then put it into some kind of spreadsheet or something, and then kind of look at a trend, right? Like, I couldn't even imagine how much time they spend doing this. So now they get alerted if there's a problem, right? So they don't need to collect that. So they're quite enthusiastic about that. In terms of the evidence and the quality, we redid that RCT, so we have some buy-in from the clinics, which is great, and I think that goes a long way. And in the general scheme of things, a specialty clinic is not that complex compared to primary care or even home care nursing, right? They're all in one spot. You kind of, you have one location to deal with, and they all work together, which is amazing, right? So the workflow's somewhat complex, nothing compared to some other models. In terms of the future, we are launching in the next couple of weeks, and we'll grow the program. But we do see kind of like a vision beyond that. And I don't mean scaling in terms of just sites, which we are planning on doing, but how do you get from a few tens of patients to hundreds of patients to thousands of patients, right? Which is what we're trying to do. So we're looking at the different models, and shortly after, what we have on the right-hand side, we call it the Cadillac version, right? So it's kind of the expensive version, which is really not that expensive compared to hospitalization, but it's our most expensive version, which is those Bluetooth-enabled devices. We give them the cell phone and a data plan, right? But again, eclipsed by any hospitalization savings. But the next tier would be something that would enable them to manually enter information. So for those who are maybe more able to do that, they could have Bluetooth devices, because those are getting very cheap as well. But they could enter, their weight, for example, and we could leverage their home Wi-Fi, because a lot of people are getting home Wi-Fi already. So again, cheaper version. And then our third tier would be a true bring your own device option, right? So you would have your own cell phone, and then you just download this app, right? And at that point in time, there isn't a huge argument for getting patients out of the program, right? Because there really isn't that much of a cost. So again, we're trying to scale. So I do have a little bit of time left, so I'm going to talk about the less sick and prevention at this point in time, which is the majority of the patients, even though they don't account for the majority of healthcare spending. And this is an interesting area, because there's actually less barriers around here, because it's driven by consumer demand and payment. And there's lots of advancements here, and especially around wearables and sensors, right? And it's been shown that if you have connectivity to sensors, it will drive use of your app, right? So, for example, the Fitbit. I'm sure everybody has used or knows somebody who has some kind of activity monitor right now. So common, getting so cheap. One of the applications we have that I show here is a type 2 diabetes application that one of our students is working on, Shivani Gowal, a PhD student. And she's trying to not only monitor blood sugars, but looking at activity and eating, right, to help these people. We're also developing a lot of continuous sensors, which is very exciting, right? So on the left-hand side, actually your right-hand side, you see there's a continuous ECG. So the idea here is it's like a Band-Aid now, right? It's a patch, a Bluetooth-enabled patch that you can wear for hours or days to monitor your ECG, right? So you're not tethered now with that Holter monitor, right? So this has huge applications around, diagnosis, all kinds of interesting things. And then we have also continuous EEG capabilities now. And of course, you'd have to wear a cap or something over it and hide it, because you certainly don't want to be ambulatory wearing that, especially if, we're targeting mental disorders around there. But, huge applications around, diagnosis and therapy in that, and continuous information, right? And follow them wherever they go, so they're not homebound anymore or hospital bound. A lot of activity around glucose monitoring. This is the glucose, the Gluco Watch. So basically, you just wear this watch, and it continuously takes your blood sugar readings. This is actually not it's not available anymore. It was not very accurate, and even worse, it was burning patients. So they don't have that anymore. But the idea is still out there. And very novel things such as contact lenses, right, to get continuous glucose readings as well. Something that is not as far off that you might think are implantable devices. And I give an example here, which is really around the corner, and that's the artificial pancreas. And our group is working around standards so that the different components can talk to them in terms of the different manufacturers developing the different sections. So basically how it works is you have a continuous glucose monitor. And right now, it's a little electrode that you embed, and you keep it in for about 3 or 4 days. So they're working on things that you keep for years, right? And I think they're in the stage 3 trials now, where you actually embed that continuous glucose monitor, and it could be there for years, right? So this continuous glucose monitor goes to the controller, which could be like a mobile phone. And then from there, it sends, it analyzes the data, and then it could send information to the insulin pump. Right? So there's a closed loop system right there. And again, not that far off in terms of this being used widely. Another concept that's really exciting and is already being used is gamification. I already mentioned that we had an app that we partnered with Heart and Stroke Foundation. This is called Less Than 30 Days. So the idea here is that in less than 30 days, you could break bad habits and build good ones, right, around your heart health. So you do initially you do a little quiz to see what your risk factors are, and then every day you get a challenge. So if one of your risk factors is around your diet, here's an example where you plan to have fish for dinner tonight, and it says small P.S. fish and chips don't count, right? So you try to do those challenges. You can skip a challenge, but it has a lot of these gamification types of concepts around there, including getting rewards, etc. What was also interesting about this was that there was huge uptake. So within that period of time of 6 months that we were tracking it, there was 70,000 downloads, right? Which is huge. And out of those, 5,000 people completed the 30-day challenge, which was, again, very, very good. What was very crucial in terms of getting those numbers was a promotion by Heart and Stroke. They did a fantastic job at promoting this. And they even had a period where if you downloaded, you get 25 air miles for free. And it spiked, right, the downloads. And if you think about it, 25 air miles doesn't buy you hardly anything, but people love free stuff, right? And I think that's a take-home message. You give them anything free, and they'll do it. So anyways, that was one of the projects. BANT is a diabetes app that we have. This version is targeted for kids, for adolescents, and we partnered with Sick Kids to do this. And we put in a lot of gamification, so leaderboards. There was a way where you could get points by doing self-care, and then with these points, you could go to the Apple Store and buy iTunes, like songs, games, Angry Bird, whatever you'd like. And this was very successful in terms of doing that. We also had a social networking component here, and we have a version of BANT actually on the iTunes Store that's free, and I think it's in something like 10 different languages right now on the iTunes Store. And again, you could download it for free. So the social networking component, the kids were talking to each other, not so much about diabetes, but kind of what they bought with their rewards. but it got the conversation started. What was exciting about this, though, was that we found that there was a 50% increase in daily testing from this. So again, like a huge change in behavior from this app, right? So kids were testing 50% more. So I'm going to wrap up now and leave some time for questions, but what's really kind of coming down the pipeline, I think, and everybody's talking about, is big data. And I think there's a huge potential for mHealth to be contributing into what we call now the big machine, right? So it's not just the data, it's how do you use this data to come out with positive health outcomes, right? And you're merging all these different types of data elements. So things such as the sensors, of course, the remote patient monitoring, obviously from mHealth, even things like you could collect public health data through apps, right, which is being done quite a lot right now. Genes and markers, there's even an app where you could get your genomic sequence. So you could just send it out and you get a kit, and then you use your app to get information. So all this data, all this continuous data can be fed into the big machine and used to help with positive health outcomes. So let me wrap up. So at the beginning, the title I had of this talk was The Promise and Reality of mHealth. And I think really the promise is a huge transformation of our healthcare system, right? From hospital, right, which is based right now, everything is pretty much around hospitals and physician offices, to the home, right? Nobody wants to go to the hospital if they don't have to. They get sick in hospital, right? They get even sicker while they're in hospital from all the other people who have germs and diseases, right? So keep them at home, and this is where they want to be. The second point is around being reactive, right? Right now, you get sick, you get worse, you go to the hospital, right? So to something that's more proactive, more around self-care, right? More around communication that's in time with your clinicians. And this concept around discrete healthcare, right? So something happens to you, you do something. Now there's opportunities for continuous monitoring, right? Continuous healthcare that's in partnership with the patient and the healthcare providers. The other side, the reality, healthcare change is slow and hard. I'm sure I'm not telling you anything you don't know, right? It's a hard slug. The technology is always the easy part, and I'm an engineer by background, and I can say this, right? Like, sometimes it's not easy, so I put easier, right? But certainly the hard part of getting things out there is around implementation. It's around finding the funding models, the business models, getting the buy-in, right? Understanding the workflow so that you can insert it without, changing the way that the clinicians work in a worse way and that they'll stop using it, right? Those are the hard things. And there's lots of those system barriers for healthcare change, right? There's ways around it. I mean, progress will happen. We need to keep kind of hitting those barriers and bringing those down. And finally, I think around consumer mHealth, it's coming or it's already here, right? And again, it's not really driven by us as researchers or healthcare administration and management. It's driven by the consumer, right? And they're paying for it and they want it, and it's already here. So let me just end by acknowledging a huge group of people that I've had the pleasure of working with over the last 10 years or so, probably more. The eHealth Center for certain, all our clinical partners, all our funding partners, industry partners, and all those patients that have been so wonderful in participating in our development process as well as our trials. So I do think I left a little bit of time for questions, and happy to try to answer them. Any questions? Oh.
Start with one. Thank you for that presentation, Emily.
Thank you.
Maybe you might not have to repeat the question for the folks.
Oh, yes, okay.
The whole notion of continuous monitoring ties into this big data perspective, because obviously now we have unprecedented amounts of data, moment-to-moment monitoring. Can you give us an example or give us a sense of how this additional data can positively impact health outcomes?
Right. So I think I'll try to paraphrase. So I think what you're asking is how all this data that we're collecting right now, even in a continuous way, can be used to help health outcomes. So again, I think there's always two sides of the coin, right? So I really believe in the power of self-care, right? And a lot of what we do is helping patients and their informal caregivers make informed decisions, change behavior positively, and again, they need the tools, right? They don't have the tools to do that, and no one is more invested in your healthcare as yourself, right? And so I think with all this continuous data that we have and all this thing, we could have, again, those times of need to filter all that data and provide them with information on what to do, right? Because they need suggestions, right? And a lot of these apps, I mean, a lot of examples, for example, of coping with pain, for example. Wonderful work coming out from the kids right now around that. And what are some of the techniques that patients can do to mitigate some of this pain, right? Around meditation, distraction, all kinds of very interesting ways of doing it, and not just necessarily medication, right? So some of these apps that are being developed are trying to help patients. I'm just giving an example around pain management, and shown to be very effective right now. The other side of things is, again, around the clinicians and the healthcare providers. So, and there's by no means do I ever suggest that any clinician should be looking at all this data, and nor can they, right? I don't think that they could even assimilate all these different sources of data. But what is very exciting around artificial intelligence and expert systems is that we could develop some very sophisticated, but yet very useful and safe ways of alerting and providing options for clinicians even, and synthesizing all this data into something useful for prognosis, for example, and prevention potentially, right? So we're always looking at these huge registries now, and there's lots of opportunities to look at these big populations of patients. How do you gain information around, who might be susceptible to some certain disease, right? And how do you potentially even prevent it? right? So I think a lot of interesting work is going around that area. Yes?
Comment and a question. So first, I think the discussion of the reimbursement aspect is really interesting. And it does kind of remind me of how our reimbursement system in general is not geared toward preventative care, but instead of managing sort of when things go wrong. And I think it'll be interesting to see how these kind of consumer market forces start to maybe driving some of that change. My question is around balancing concerns of sharing personal health information and privacy through mobile devices, which I think is one of the bigger barriers to this as well.
Okay, so I won't recap the first part, but your question was around how do we mitigate around those privacy and security concerns. And there's lots of different ways around that. Right now, we work very closely with a privacy officer, so whatever we build obviously goes through them. Right? There's always informed consent when using applications, or our applications, not necessarily everybody's applications, but there's ways of getting informed consent so that they know what they're getting into. We also have, our applications are all linked to our servers, so if necessary, we can actually remotely wipe all the data from there. All the data is encrypted. And so when it's traveling through the air, you're not going to really know who's it's from, for one thing. And around the other comment I would make is around patient perceptions. Of course, healthcare data is you need privacy, right? You need those safeguards. But then again, if you talk to the patients, they don't care that much usually, especially those sickest of sick patients. They don't really care if they know, their weight is being transferred over, right? They want that help, right? So we put all these safeguards in, but the patients, some of them, you got outliers, but in general, when we talk to them, they're probably less concerned than we are, especially those sickest of sick patients that we tend to work with right now. There's also, again, some very novel things that are coming down the road around biometrics that can be used to kind of make sure that the patient is the right one who's accessing the data, authentication methods. So, I like to draw a parallel to, our banking system, right? Because people use apps all the time for your banking information, and everybody is very nervous about their banking and their money, right? And yet there's ways of doing it for banking. I know there's ways of doing it for healthcare. I just think we need to kind of wrap our minds around that. It's really, again, not the technology, I think.
So if a physician is accessing this information, do they access it on their phone or on a phone that you provided them? And in what form does that sort of alert and that patient information come to them?
Right. So the two ways that the physician can get information, which is what you're asking around, the email alerts that we send are actually sent within our hospital system, so it's within our secure network. So their phone is part of the hospital network, right? The other way is to get information through the website, and again, they have a password. It's password protected, so they're only supposed to be seeing their patient's information. Yes. Is the question at the back?
I guess this is a different way of looking at the privacy issue. This was a fantastic talk.
Thank you.
And I'm working with kids to try and develop some apps around healthy lifestyles.
Mm-hmm.
So we've also interviewed their parents.
Mm-hmm.
And said, would you want to see what your child is putting into the app on their daily lifestyle?
Yes.
So again, in order to engage kids, they might not want their parents to be looking
Mm-hmm.
at them. So there's just a different kind of, another whole set of privacy issues when you're looking at how can we engage kids to use apps.
Oh, absolutely. I mean, that's an excellent point. There's no question, so I'm not going to repeat it. But I do think that that's a very interesting topic around. And again, we've worked with the kids hospital quite a bit, and and it's interesting because you're looking at little kids, right, who under age of 10, are different also from the adolescents. Right, and so you have to kind of see what age you're targeting, because it really changes from like 15, right? The teenage years are very different. So again, all those, it's so context dependent on what you need to do with that, but point well taken, yeah. Yes.
Okay, so based on your experience with data, do you think, is it possible right now to create a fully AI doctor that we enter our information, our symptoms, and it can give us a basic diagnosis of what should we do next, something like that. If you have a cold, or if you have some symptoms of some kind, you're nervous. Do you think it's possible to have?
Right now, no. Well, I just think but I don't even think it, again, I don't know if it's a technical, I mean, technically that's a hard question, right? Because there's all kinds of safety concerns, but it's a whole mental shift, right? Around what doctors do and what they trust and what patients trust as well, right? So I think there's two sides of that, right? Right now, the artificial intelligence, like there's so many possibilities, and a lot of doctors like to, like especially, you know, I was kind of looking at telehealth as an example, right? That first initial interaction is really important around the rapport, like communication around somebody, and sometimes patients, they actually do like to talk to real people, right? And that's, you know, there's all kinds of interesting psychological kind of issues around there, around some people actually like coming to clinic, right? So hemodialysis patients, sometimes they like to sit in the clinic because that's their social outlet. Right? But anyways, that first kind of initial interaction with your clinician is really quite important. And then after that, there might be more of an ability to kind of use other technologies, such as like telehealth, for example, to, you know, for mental health, for example. You might not need that face-to-face, but that first initial one, I think, is important to build that rapport. So there's other things beyond just getting a diagnosis, right?
From the technical point of view, do you think like we have good enough data, or do we have enough like sophisticated AI systems to do that?
I don't think you could trust it, honestly, right now. I mean, there's so many, I mean, I'm not a physician, but I mean, like, there's so many variables to take a hold of. I wouldn't know how you would, it would be such a complicated, I mean, all the diseases in the world, right? Like, that's such a complicated thing right now. And again, I don't think people would trust it right now. I mean, you have things like Watson, right? IBM Watson. And, you know, that's a supercomputer, but still, I don't think that Watson would be able to diagnose people, or would they trust it? And you would still need a second opinion, which would, you know, negate the use of that, right? Yeah.
Next question. So when we look at the healthcare and mobile space, you see big names like Microsoft and Apple, and they're driving all these new products. Do you feel that it's just going to be a catch-up game with what's not the UHNs that are always driving these brand huge products? Like, are we going to be always a little step behind, or trying to catch up?
So is your question, are we always going to, as researchers, behind the big companies?
Yeah, and they're just kind of pushing farther and farther ahead.
I would say it's almost the opposite, right? Because those big companies, it takes a lot for them to actually switch gears, right? So if you look at, I'm not going to name names because I'll get in trouble, but if you look at some of these big companies, right, they're using the same technology over and over again, right? Not all of them, but a lot of the big ones have a really hard time kind of wrapping their mind around and switching gears, which especially around hardware, it's slow, right? So if it's a medical device, have you noticed how hard it is to get a change in medical devices? I mean, you would think by now we would have Bluetooth everything, right? But we, like, I don't know, it was probably like 10 years ago, we developed a Bluetooth adapter for glucometers, right? And we thought, okay, this would be a stopgap for a year or two. 10 years later, we're still using it sometimes, right? And just now, you know, we're working with companies who are just getting out these Bluetooth-enabled devices, right? So, you know, I think that being smaller, being more nimble, having less, you know, need to get the revenue at the beginning, and I think that's one of the reasons why it's hard for these big companies, because they've got to prove that this is going to make them money, right? And in this space, there's not a lot of business models, right? So how are they going to make money off the bat and really, you know, be secure that their return investment is there at the end? And with our space, it's tough. In the consumer space, less tough, right? Because people want to buy activity monitor, like trackers and stuff like that. So again, I think sometimes it's flipped, right? Like some of our research is probably more cutting edge than these big companies.
Great. With that, I'd like to thank Emily again for giving us a very educational talk this afternoon on health and expanding our vocabulary on nomophobia. I don't have a name for all the aches and pains of researchers.
Yes.
So thank you very much.
Thank you.